of have included healthcare and public health, professional disaster preparedness, surge capacity. She publishes lectures on bioterrorism and pandemic planning, emerging infectious diseases and infection control. She is a member and past chair of the Association of Professional Infection Control and Epidemiology Emergency Preparedness Committee. Now, she was going to give her own interaction, and I'm now going to pass it on to Terri to really tell us about herself. Thank you, and welcome to the Fell Mirowitz Center Zoom program.
Thanks for having me. I appreciate it. I apologize, I'm going to turn off my camera because Zoom likes to kick me off if there are too many people on because my internet gets unstable. So I'm just going to stop my video. And I'm going to share my screen so you can see my slides. So assuming everyone can see my slides, I will get started.
Great.
So, looks good? Awesome. Okay. So as was just mentioned, my name is Dr. Terri Rebmann. My position for this year is Special Assistant to the President at St. Louis University because I am assisting our President's office in our reopening plans for the pandemic. And I'm also the director of our Institute for Biosecurity at the university. So today I'm going to talk about COVID-19, where we've been and where we're going in terms of the pandemic. So the objectives, I'm going to describe how the pandemic started. I'm going to briefly describe the epidemiology of SARS-CoV-2, which is the virus that causes the disease COVID-19. I'm going to explain how COVID-19 is transmitted, or as we believe it is to be, how we think that it's transmitted based on current science. And then I'm going to predict the remainder of the pandemic, and I say because no one knows exactly what's going to happen with this event, but I'm going to talk about the science behind pandemics and what we might see this fall and moving forward. So a quick disclaimer, everything in the slides is updated as of this weekend when I updated the information for the presentation. What's really helpful is to check the CDC website, or if you are employed, check your employer's policies, because the recommendations related to COVID-19 are changing really rapidly based on our science, like what we know about this particular disease and how it's spread. What isn't helpful is what we saw early on in the pandemic, where people were doing things like hoarding toilet paper and sort of stocking up on the wrong kinds of supplies and focusing on the wrong or misinterpreting some of the science and then making bad decisions about what you need to do to protect yourself from becoming infected. So an example of that would be, one thing that isn't helpful is to disinfect your groceries, for instance. We now know you don't need to disinfect boxes in order to protect yourself from infection. And I'll talk more about that later on. Just wanted to note, this presentation is intended for the general public, so there's specific information that's very different if someone is a healthcare worker or if you know somebody who's a healthcare worker, and I'm not going to cover any of that information because it's just a more detailed kind of presentation. All right, so let's get started. So on December 31st of 2019, China informed the World Health Organization about a cluster of pneumonia cases that they were seeing in Wuhan, China. And this cluster of pneumonia cases had an unknown cause. So they were worried, but they were investigating, trying to figure out what was going on. But things escalated really quickly. Just 3 days later, that initial cluster had grown to 44 cases. So it was very apparent early on that this was going to be a very large outbreak. On January 7th, we identified that this was a new or novel coronavirus that was the cause of the outbreak. And then on January 13th and 14th, we already saw cases being reported in Thailand and Japan, which really showed how quickly the event spread and escalated just extremely rapidly. So originally, you may remember from the news, they thought that this disease had started, or the outbreak had started in a seafood market in China. And we thought that it was only a zoonotic disease. We originally thought it was tied to pangolins, that picture of that lizard creature on the slide. But it turns out that, well, one, it's not just zoonotic, it's also spread from human to humans. but two, we know that it didn't actually start in that seafood market. We also know that it's not really tied to pangolins after all. Once we did the viral sequencing, or the genetic sequencing of the virus, we realized it's actually a recombinant virus that's a cross between a bat coronavirus and a species origin unknown coronavirus. So this is just a new coronavirus that popped up organically, spread to animals, which then spread to humans. And we now have evidence that this disease actually probably started in October or November of 2019. So SARS-CoV-2, the virus that causes the disease COVID-19, like I said, was first identified in December of 2019, but again, we think it was probably circulating in China as early as October or November of 2019. Since it first emerged, it spread globally really rapidly. So as of August 29th, when I made the slides, there have been more than 25 million cases worldwide and more than 843,000 deaths related to COVID-19. And then the US is having a very bad experience with COVID-19. I'll talk a little bit about some of the reasons why. But similar to what's happening globally, so the US is experiencing a large increase in cases. As of August 29th, we had 5.9 million cases and more than 182,000 deaths related to COVID-19. The US now has more cases of COVID-19 than any other country in the world. Almost all the states are reporting widespread community transmission, although some are just seeing it in defined areas. Although we're starting to see sort of a general decrease in cases across the US, there are still multiple hotspots in the US, and St. Louis is one of those. So you're considered a red spot or a hot spot for cases. We still have a very high positivity rate and an increase in cases happening in the St. Louis region. But in general, urban areas are being hit harder than rural areas in many parts of the United States. So coronaviruses. Coronaviruses are respiratory viruses. They were first identified in the 1960s. They're named after the crown-like spikes that are on their surface. In Latin, the word corona means crown or halo. Now, we have human coronaviruses that circulate every year, and they cause just a mild respiratory illness that's similar to a cold. But we have had 3 novel coronaviruses that have emerged since 2002. The first one was SARS-CoV, the original. We now kind of call it SARS-CoV-1. We had MERS-CoV that emerged in 2013, and now, of course, SARS-CoV-2 or COVID-19 in 2019. These novel coronaviruses cause much more severe disease than the coronaviruses that circulate every year. But scientists don't yet understand or know why these novel coronaviruses cause more severe disease than what we see circulating every year. But we are kind of hopeful that as SARS-CoV-2 starts to move through the population, that it might mutate and actually become a more mild disease, more like what we see with the other human coronaviruses that circulate every year. Most infected people, about 80% of those, are going to have a mild illness. But about 15% of all people who get infected will require hospitalization, and about 5% will need intensive care in a hospital. Now, in contrast, only about 1% of people that get flu every year require hospitalization. So COVID-19 is a much more severe disease compared to influenza. Adults, especially those who have comorbidities, and people who are over the age of 65, are at higher risk of severe illness and death. People that have comorbidities have a mortality rate that's about 10%, and people who are over the age of 70 have a mortality rate between 8 and 15%. Now, in contrast, the mortality rate for people that don't have a comorbidity or people who are under the age of 65 have a mortality rate that's less than 1%. As you can see on the slide, the age distribution of people that require hospitalization is skewed very heavily towards older individuals. Now, in contrast, children are much less likely to even become infected. They're only about 2% of all cases globally, about 6% of all cases in the United States, and fewer than 1% of infected children require hospitalization. So most kids have very mild or no disease at all. But a really interesting phenomenon that we're seeing with COVID-19 that we haven't seen with other diseases is that the mortality rate is really affected by what's happening in the community in terms of healthcare surge capacity. So when a healthcare system becomes overwhelmed and they're not able to take care of the sick patients, then the mortality rate will increase. So the goal, therefore, is to keep disease severity at a low enough level that our hospitals are able to manage those people that do require hospitalization. Because when our disease rates go up and we have more people being hospitalized, the mortality rate will go up if the hospitals are not able to provide care to everybody who needs it. So now I'll talk about COVID-19 transmission. There have been a ton of rumors and misinterpretations of the science behind this disease. But it is important to know that the science is evolving. And so this is one reason why I'm sure all of you have noticed that our recommendations, and by our, I mean like the CDC and public health, our recommendations about how to handle this disease have changed a lot over the last few months. And that's because as we learn more about the disease, we change our recommendations based on what we know. So let's talk about what we do know. So I'm sure that you've all heard the controversy about whether this is an airborne spread disease. And before I talk specifically about COVID-19, I want to differentiate between like what we mean by the word airborne versus respiratory droplet spread disease. So some diseases can be spread by respiratory droplets, and respiratory droplets are large, wet, and heavy. And they come out of the nose and mouth of somebody who's infected, and because they're really big and wet and heavy in general, they tend to fall, most of them fall within about 3 feet of the infected person. And they tend to fall to the ground really quickly. They're not going to stay in the air for long periods of time. Now, in addition to those large respiratory droplets, some infected individuals can release a small percentage of some smaller respiratory droplets, and those can drop as far as about 5 feet from the infected person. But it's not really even that black and white. It's possible that some of those smaller infectious droplets can actually travel a little bit farther. So it's not as though if you're standing 4 feet 11 inches away from the infected person, you're really, really high risk. But if you're 5 feet 2 inches away, then you're completely safe. There's some gray area here in terms of what your actual risk is. It's possible some of those smaller infectious droplets can go a little farther than 5 feet. But we don't know if enough of those droplets can go farther than 5 feet to actually cause an infection. But this 1 to 5 foot range for respiratory droplets is the basis for our social distancing. So that's why we say to stay 6 feet away from other people, because if you're at least 6 feet away from other people, then you're out of the range of the respiratory droplets that would come out of the nose and mouth of infected people. Then there are other diseases that are airborne. And airborne spread diseases generate airborne droplet nuclei. And these are really, really tiny infectious particles, and they're so small, they can attach themselves to dust particles, and they can be carried on air currents for really far distances. So for a disease that's truly an airborne disease, like measles or tuberculosis or smallpox, those particles have been able to spread even like multiple floors of a hospital, for instance, and they stay in the air for hours at a time. So airborne spread diseases spread really quickly because they can spread very, very far from the infected person. But both respiratory droplets and these airborne droplet nuclei come out of the nose and mouth of the infected person anytime they sneeze, they cough, when they're talking, or even just simply breathing. But if somebody is coughing or sneezing, then they're putting a lot more infectious particles out into the environment. Then there's a separate category of disease transmission, what we call contact spread. And with this form of disease transmission, there's a contaminated object between the infected person and the uninfected person. So for instance, in the slide, you've got the guy who's sneezing. He sneezes onto the table, so his viral particles are then sitting on the table. The next person comes by, they put their hand on the table, and then they touch their eyes, their nose, or their mouth, in particular their nose or their mouth, and that's how they become infected. So there is a risk to individuals who touch a contaminated surface if you then touch one of the mucous membranes of your body, because Your nose and your mouth in particular is the primary way that these respiratory droplets and viral particles get inside your body and cause an infection. This can happen whether you're wearing gloves or not. So gloves are not meant to keep all the viral particles off of your hands or out of your body. They're just meant to decrease sort of general bioburden, and primarily just in healthcare. They're really not intended for the general public to try to stop the spread of disease. But it's important to know that not all diseases can be spread by the contact transmission route, even if we find that diseases or these viruses can live on surfaces. So that brings me to COVID-19. So how is this disease transmitted? So one more quick disclaimer. One of the challenges, one of the things I really like about working in the field of emerging infectious diseases, but also one of the challenges, is that we don't know exactly how these diseases are transmitted until we have collected enough data about that disease. So early on, we're sort of making educated guesses about how we believe the disease is transmitted. And we're still learning about SARS-CoV-2. But based on what we know so far, the virus is believed to spread to close contacts primarily through respiratory droplets when an infected person is coughing or sneezing. Now, there's also some evidence that there is increased risk of virus spread during what we call infectious aerosolizing procedures. And these are medical procedures that generate an infectious aerosol. So in other words, these are medical procedures that cause an increase in viral emission for a short period of time based on what that procedure is being done to the person. So for instance, if somebody is having difficulty breathing and a physician needs to put that person onto a ventilator, they will put a tube down that person's throat. That's called intubation. And the process of putting that tube down somebody's throat usually makes that person have a severe cough reaction. That cough reaction related to intubation creates this temporary aerosol. Basically, it makes it almost like an airborne spread disease for this very short period of time. And that is really, really high risk for healthcare workers, because if you're standing next to that person as they're being put onto a ventilator, there's that massive burst of virus that is put out into the air, and they are really tiny particles. But these aerosolizing procedures are only involved in medical procedures. So these procedures are not anything that would happen in the general public. So none of you would be exposed to an aerosol generating procedure unless you just happen to be in the hospital room of somebody having one take place. So again, we primarily think that this disease is spread by respiratory droplets, especially in community settings and in homes. But we also have some limited evidence that a person can get COVID-19 through contact with a contaminated surface. But this is not believed to be the primary way that the virus spreads. And here's where the controversy came about the contaminated environment. So as I just said, COVID-19 is believed to primarily spread by respiratory droplets. So that to me is the biggest concern, are the respiratory droplets when you're in close contact with somebody who's infected. But we do have studies that have found that the virus can survive on hard surfaces up to a few days. And it's possible that the survival of the virus on those hard surfaces might be able to transmit infection, but it's a little unclear. Survival times for various surfaces are listed on the slide. So there might be some risk with these hard surfaces. Again, we're really not sure. We also have studies that have found SARS-CoV-2 can survive on fabric and soft materials, and also on cardboard or even other types of paper for up to 24 hours. But we don't believe there's any infection risk with those soft surfaces or with paper or cardboard. And there's a couple of reasons for that. It's harder to catch the virus, to move the virus from a soft surface like fabric or from paper or cardboard than from a hard surface like a desk or a door handle, for instance. So again, we don't think there's any infection risk with soft fabrics or any kind of soft furniture, nor with paper or cardboard. So there might be this small risk related to these hard surfaces in the environment. But it's important to keep in mind, the amount of live virus is going to decrease over time on hard surfaces. Viruses just don't survive that long outside of somebody's body. So within just a short period of time, within minutes to an hour or two after somebody, let's say, sneezes or coughs, into the environment, there's less than 0.1% of the starting viral material. So for instance, if I was infected with COVID-19 and I sneezed on my desk right now, my keyboard and my desk would be covered in viral particles, billions of viral particles. But within minutes or a couple of hours, that viral load is going to decrease exponentially. And it's going to be much harder to be able to get that virus off of that hard surface over time because there's just not as much there. And just because the virus can survive on a surface doesn't necessarily mean that it poses an infection risk. You have to have a way of getting that pathogen, that virus, from that contaminated surface, like my keyboard, into your body as a person who's uninfected. And there has to be enough virus when you do that to actually cause an infection. So this is really just kind of a theoretical risk at this point. But because we do have this low theoretical risk, so it's possible that my husband, let's say, could walk in later tonight, touch my keyboard, and then touch his eyes or his nose or his mouth, or become infected from my COVID-19 virus that's on my keyboard. But we don't actually have any examples of this happening in the real world. It's all sort of theoretical. But because there is this theoretical risk, the CDC says that we need to be careful to disinfect our environment and make sure that we always perform hand hygiene after you touch something that might have been contaminated, just as a way to just further eliminate that risk altogether. But really, from an infection risk, close contact with an infected person, being closer than 6 feet to somebody while you're not wearing a mask is going to be a much, much higher risk than touching contaminated surfaces. So in my mind, when I'm talking to people, when I'm talking to my family, my kids, I always tell them, I'm much more concerned about you being close to other people when you're not wearing a mask. But please wash your hands after you touch the environment before you touch your eyes, your nose, or your mouth. That's going to further decrease your risk. But again, I'm much more concerned about the respiratory particles getting into the eyes, the nose, or the mouth, in particular, the nose and the mouth. So we know SARS-CoV-2 is a really contagious virus, and nobody is believed to have natural immunity against it. So experts estimate that between 30 and 40% of everybody is going to be infected with COVID-19 before the pandemic ends. Now we talk about how contagious a disease is by a term we call the basic reproduction rate, or the R0. The R0 for COVID-19 is believed to be between 2.2 and 3.1, meaning that each infected person is going to spread that disease to 2 to 3 other people. And that's why the disease spreads really, really quickly. If the R0 was like 1 or less than 1, the disease doesn't spread as quickly, or potentially doesn't spread at all. Now, individuals with COVID-19 are believed to be the most contagious when they have symptoms and when their symptoms are the most severe. In other words, when they have a fever and when they're coughing. But we do have studies that have found that people shed virus a day or two prior to having symptoms. That's what we call pre-symptomatic shedding. And in addition, there are people that never have symptoms, they are asymptomatic, that can also shed virus. But we don't know the exact role that these asymptomatic people play in disease transmission. Our epidemiological evidence indicates that the symptomatic people are associated with the most disease spread, followed by people who are pre-symptomatic. In other words, those who go on to develop symptoms shed significantly more virus than the people who stay asymptomatic the entire time they are shedding virus. So how do we define an exposure to COVID-19? Well, in order to be considered to have had an exposure, you have to be a close contact. And a close contact is defined as being within 6 feet of an infected person for 15 minutes or longer while you're not wearing personal protective equipment, in particular without wearing masks. An exposure can also be caused by having direct contact with the infectious secretions from somebody who's infected. So for instance, having somebody cough directly on you, even if you spend fewer than 15 minutes with that person. So essentially, you need to be around somebody who's infected for a relatively long period of time in order to have an exposure to them. So that means for the vast majority of people, you can prevent most exposures by staying 6 feet away from other people as much as possible, and then wearing a mask if you have to be in public. Now, it's different for healthcare workers because they have just, they have a much higher level of risk because they are literally in the face of infected individuals, and often those infected people are not able to wear a mask because some of them are having difficulty breathing. So healthcare workers have to be within inches of somebody who's infected, and they're coughing on them and sneezing on them, and they're doing those medical procedures that create those temporary aerosols. So healthcare workers are at much higher risk. So they wear a different level of protection than those of us in the general public. But infection risk is actually more complicated than the way that I just sort of broke that down. So there's a number of different factors that go into your actual risk of being exposed in any particular situation. So for instance, one factor is how much virus is that infected person actually putting into the air? If the infected person is wearing a mask, that mask is going to block a lot of their respiratory particles, and so they're not putting as much virus into the air. If a person is just simply talking, they're not going to put as much virus into the air compared to if they're singing. So we have some preliminary data that shows that when you are projecting your voice or when you are singing, that you put more virus into the air and that the virus travels farther. So that's one reason why choirs and singing engagements either have people wearing masks or they try to separate them even more than 6 feet apart to try to cut down on disease transmission, because we have found there's a little bit of evidence that that might be a higher risk. Then there's also this risk related to what is the environment around you, what's happening in the environment around you in terms of, is the air flowing or is it kind of dead or stagnant air? Are you in a large shared airspace or are you in a tiny airspace? So if you're in a very large room, there's only one other person in that room with you, even if that person's infected, that's going to be lower risk than if the two of you are in a smaller space and one of you is infected, because there's going to be just more virus in the air around you in those smaller air spaces. There's also, in general, a higher risk being indoors versus being outdoors, because outdoors you have the sun that kills a lot of the virus, you've got air currents, you've got more air to dilute the virus. So in general, it is safer to be outside than to be inside. Also, the amount of time you spend in shared airspace with somebody makes a difference. So if you're in a shared space with somebody for 10 minutes, that's going to be much lower risk than if you're in a shared airspace with somebody for multiple hours, for instance. Then just how crowded an area is. So if you're in a room where everybody is, just a foot or two away from each other and there's a large number of people, that's going to be a much higher risk area than if you're in a space where there's only a few of you and you're more spread out. And then lastly, the last thing that relates to infection risk is whether or not you are wearing a mask. Because if you are wearing a mask, that's going to provide a certain level of protection to you, depending on the kind of mask that you're wearing. So when you look at this as a whole, you kind of come up with this sort of infection risk in general, but because it's very complicated in terms of all the factors that I just described. So now let's talk about mask use prior to COVID-19 for the general public. So prior to this pandemic, masks for the general public were basically only used, for the most part, in Asian countries. So for instance, during SARS-CoV-1 in Southeast Asia and in Canada, there was widespread mask use in the general public because that disease was spreading so very quickly. So you can see the adorable little ballerinas on the slide. They're all wearing masks. And if you had seen the audience of all the parents and the families and friends, they would all have been wearing masks as well. During the H1N1 pandemic in 2009, we had discussions about whether we were going to have people wear masks in the general public. And in some countries, like in Mexico, they did have people wearing masks when they were out and about. We chose not to do that in the United States, although some people decided to do that just on a one-on-one basis. But we didn't have a mask policy related to wearing masks publicly. What's interesting to me as somebody who's worked in this field now for more than 20 years, DHHS, prior to COVID-19, had actually recommended that families stockpile masks and other PPE for the next pandemic. So their original recommendation had been that each family needs to have 20 masks per family and up to 100 if you ever had to ride public transportation. But for the most part, most people didn't do that, which in some ways makes sense because most people don't have a personal disaster plan anyway, because we're also all supposed to be stockpiling food and water and keeping enough supplies on hand that we could be self-sufficient for a few days in case of a natural disaster. And the vast majority of Americans do not have a personal disaster plan of any kind. And even those that do, most did not have stockpiles of masks or respirators. My family and I were the exception, and my kids made fun of me for years about my stockpile of masks that I kept in my basement. They stopped making fun of me during the pandemic when I was the one who actually had boxes of masks that we started giving out to our friends and family so that they had some to wear out in public during the response. Now, mask use for the general public during COVID-19, I'm sure all of you have noticed the recommendations have changed over time. So originally, the CDC had said they did not want the general public wearing a mask unless you were actively sick. And so the thinking at the time was, if you are sick, you put a mask on yourself, and that works as what we call source control. It cuts down on the amount of virus that you're shedding out into the environment, so you're decreasing the risk of exposure to other people. But they didn't want the general public, they didn't want just everybody wearing masks while they were out and about. And there were a couple of reasons for that. One, it gives you a false sense of security. And so then you think, well, now I don't have to be socially distanced because I've got this mask on. And that's not true. It's masks and distance. It's the combination that's really the most helpful. But then also, you can actually, what we call auto-inoculate or accidentally infect yourself from wearing a mask, because the mask itself becomes contaminated as you're wearing it. The outside, in particular, will become quite contaminated because if an infected person is breathing on you or coughing or sneezing on you, those viral particles are getting on the outside of your mask. So if you touch the front of your mask where it's contaminated, and then you take off your mask and you touch your nose or your mouth, then you can become infected even though you had your mask on while you were out in public. But one of the primary reasons why originally the CDC said not to wear masks in public is that we needed to conserve them for our healthcare personnel. We really did not have enough PPE stockpiled for our healthcare personnel. We were grossly unprepared for this pandemic. Something we have known about for many, many years. Multiple studies have been done that have shown that we did not have an adequate stockpile. And we very quickly ran out of PPE, in particular respirators and masks for healthcare workers. But we also even ran out of isolation gowns. In New York City, they were resorting to wearing trash bags for isolation gowns because they didn't have enough PPE to go around. We also didn't know that we had asymptomatic and pre-symptomatic shedding of the virus early on. Once we figured all these things out, we did change the recommendation and said it is really important that people do wear masks in public because now we know that wearing masks and staying 6 feet apart and performing hand hygiene can really reduce disease transmission. So let's talk about the different kinds of masks. So there's basically 3 categories of masks. And the first one isn't technically even a mask, although we'll still use that term because it looks like a mask. And that category is what we call respirators. Respirators are a mask that's needed for an airborne spread disease. They're really tight to the face, they have a very tight weave, and they are able to filter out those really, really tiny infectious airborne particles. So respirators are only needed for airborne diseases like TB and measles. So we don't need a respirator for COVID-19 unless you're a healthcare worker and you're doing one of those aerosol generating procedures. The other 2 categories of masks are what we call surgical masks or procedure masks, or some people call them medical masks. And then there are face masks. So I'll talk about the medical masks first. So FDA approved medical or procedure or surgical masks, all the same thing. These are used in healthcare settings for diseases that are spread by respiratory droplets. So these are the masks that you'll see on healthcare workers if you were to go to a hospital or to a clinic. And they are wearing those to protect themselves from respiratory droplets from infected COVID-19 patients. And then the third category of masks are the homemade face masks for the general public. And this is a very, very broad category that can actually consist of, well, really almost anything that consists of a cloth that you put over your nose and your mouth. And I'll talk about that in more detail in just a minute. So, how protective, how useful is it for all of us to wear a mask in public? What kind of benefit do we actually get from this? Because as all of you know, this is a very politicized issue about, can people be forced to wear a mask? Should we require people to wear a mask? And does it actually help? What's the science behind this? Well, the science behind it is that the usefulness of wearing masks in public depends on how many people are wearing them and whether or not those people are infected. So for instance, if you've got somebody who's infected with COVID-19, regardless of whether or not they have symptoms, so in other words, they're a carrier, a COVID-19 carrier, if that person is not wearing a mask, then they're putting a lot of those infectious respiratory droplets out into the environment. So if you have an uninfected person who's close to that infected person, but the uninfected person is wearing a face mask, that mask that the uninfected person has on is going to give them some level of protection against exposure to those respiratory droplets. But that is not going to be 100% protective. So it is not completely protective if you have a face mask on in public, but the people around you do not. You have some protection, but still an infection risk. Now, if the COVID-19 carrier is wearing a face mask, that's going to block a lot of the respiratory droplets from even getting out into the environment. But some will still get through the mask or around the sides of that mask. So in this scenario, that's going to provide a medium to large amount of protection for the uninfected person, even when that uninfected person isn't wearing a mask, like that second scenario on the slide. But if both the COVID-19 carrier and the uninfected person are both wearing a face mask, that's going to give you the largest amount of protection against the spread of respiratory droplets. But even in that scenario where everybody's wearing a mask, the exact amount of protection provided by those masks depends on the type of mask that's being worn, because all masks are not equally protective. But let's talk about what would happen, this effect of what we call universal masking, everybody wearing masks. We have multiple studies that have shown that when everybody's wearing masks and staying 6 feet apart, it really does decrease the risk of disease transmission. So for example, on May 12th of 2020, there was a hairstylist in Springfield, Missouri, who had respiratory symptoms, and she continued to work with clients for 8 days. When the stylist actually received a positive test result for COVID-19, that's when they figured out she'd been working for 8 days with symptoms, which she shouldn't have done, but was what she chose to do. There was also a second hairstylist at the same hair salon who was infected from stylist A, and she developed symptoms on May 15th, which was day 3, and she also worked until day 8. So both of these individuals were symptomatic and continued to work at the hair salon. Over those 8 days where these 2 infected hair salon workers were working, 139 clients were exposed to those hairstylists. And those interactions involved spending more than 15 minutes with the clients, between the client and the person who's styling their hair, in very close proximity. But everybody in that scenario was wearing a mask. So the hairstylists were wearing masks and all the clients wore face masks, and there were no known secondary cases. So what that tells you is that universal masking really does work, even when the person is symptomatic and putting a lot of infectious particles out into the environment. But as I said, all masks are not created equal. Homemade face masks can be made of different combinations of fabrics, different layering sequences, and they can be made in different shapes. Now, we've only had a few studies so far that have looked at filtration and breathability of different types of fabrics or materials, and it's been shown to vary a lot by 0.7 up to 60% filtration efficiency. So for instance, folding fabric cloth into 2 layers has been found to provide 2 to 5 times more filtration efficiency compared to just a single layer of that same cloth. And the filtration efficiency will increase 2 to 7 times if you fold it into 4 layers. But the material itself is also really important. So for instance, a cotton handkerchief, even if it has 4 layers, is still only about 13% filtration efficiency. So cotton handkerchiefs are just very poor masks, in other words. But breathability is also really important. The better the filtration in general, the less breathable that mask is going to be. But it even gets more complicated than that, because it's really that combination of fabrics and materials and layers that gives you different levels of filtration and breathability. We don't have a single study that has systematically looked at all combinations to see what would be most protective. And that's why the CDC doesn't really have any specific recommendations at this time about a choice of material or the number of layers. They just basically say, have your face covered, your nose and your mouth covered, and that's good enough. But we also know that there's a lot of data that there are certainly 2 kinds of masks that you absolutely should not wear. And the first are masks that have an exhaust valve or an exhalation valve. Now, you've probably seen these out and about, or you've probably even seen them like in stores and had people recommend them. They're being marketed as being more comfortable than a standard face mask because they release humidity and heat from inside the mask. But the problem is that one-way valve allows that person's exhaled air to go through that little filter disc that's attached to the front of the mask. And it's actually putting those respiratory droplets out into the air. So it's really not filtering much of anything. It's basically just shooting the infectious disease out into the environment. So it's not protecting them, and it's not protecting any of us either. And then in addition, there are the what they call gaiters, neck gaiters. They look kind of like a scarf that you can pull up over your nose and your mouth, or then drop down to just wear around your neck. And there's been a study that has found that the neck gaiters are not only not protective for you, they don't filter much of anything, but in addition, they actually increase the infection risk, because what happens is that when an infected person breathes through that gaiter, it actually makes the respiratory droplets a smaller size, and it projects the respiratory droplets farther. So neck gaiters should never be worn by anybody out in the public, because they actually are a higher infection risk than not wearing anything at all. Now, some companies have already, like Disney, for instance, has come out and said you can't wear neck gaiters. Other companies have not picked up on this yet because CDC has not made a strong stance about it, but the research is very, very clear that you should not wear a gaiter. And it's not safe really to be around somebody who's wearing gaiters because they are exposing you to respiratory droplets if they're infected. So we know transmission occurs either when you don't have PPE at all, or if you use it incorrectly. So during the SARS-CoV-1 outbreak, we had a large number of healthcare workers who got infected with SARS, even though they were wearing respirators and eye protection, isolation gowns, and gloves, and still they were getting infected. And it turns out that what happened is that they were removing their respirator incorrectly. So if, as I said before, if you remove your respirator by touching the front where it's most contaminated, that puts you at really high risk of becoming infected. So whenever you remove a mask or a respirator, you should only remove it from the straps or from the ear loops, and keep your hands away from the mask material, which is going to be the most contaminated part, and try not to touch your nose or your mouth as you're taking that mask off. So here's kind of a comical slide that just shows ways to not wear your mask. So let's talk about how to wear a mask correctly. Well, first of all, simply wearing a mask is the best thing you can do when you're out in the public. So in some ways, wearing it at all is better than not wearing it. But it's really, really important when you are wearing a mask, if you want to be most protected, to fully cover your nose and your mouth. That's how the respiratory droplets get into your body. So you need to have those covered up so that you don't become infected. If you're wearing one of the masks that has the metal at the top, then you want to pinch the bridge of that mask around your nose so it has a tighter fit. In general, the tighter fit of your mask, the better and the more protective it's going to be. As I said before, don't touch the ties or the ear loop. I mean, only touch the ties and the ear loops. Don't touch the material part of your mask. And then don't touch the front or the inside of the mask. At the end of every day, so if you wear your mask to go out to the grocery store or what have you, when you come back, you need to launder that mask and then get a new, fresh, clean one the next day. And then hand hygiene is also one of the single most important things you can do to prevent the spread of really almost any infectious disease. And we know that it works really well, but people have to do it correctly and they have to do it consistently. So hand hygiene means to wash your hands for 20 seconds with soap and water or use hand sanitizer. And if you use hand sanitizer, you have to make sure it has at least 60% alcohol in it. There are a lot of new hand sanitizers that are on the market that have like a new great smell, so it kind of covers up some of the alcohol smell. But make sure you check the bottle or the package because a lot of those do not have 60% alcohol in them. So they're not going to be as protective. So one of the most frequently asked questions that I get is what's going to happen with the remainder of the pandemic? And I can tell you my crystal ball is a little foggy on this. No one knows for sure what's going to happen with this pandemic. And if somebody tells you they know exactly what's going to happen, they are in some ways kind of making it up. They might be a science-based answer, but none of us really know. There are some areas that are still in the acceleration phase, meaning they are having an increase in cases right now, and cases are rising exponentially. And then there are other areas that are in the deceleration phase where we're starting to see a decrease in cases, or they may even be like at the peak or at the bottom of the valley in terms of seeing the number of cases. The CDC estimates this pandemic at the least is going to last 12 to 18 months, and we are probably going to see multiple waves of patients. So with pandemics in general, these are influenza pandemics, most often we see surges in cases that last between 6 and 8 weeks, and we call these waves. So during the 2009 H1N1 pandemic, for instance, we saw 2 pandemic waves, and each one lasted about 8 weeks in length. So it's exactly what we anticipated. However, what we're seeing with COVID-19 is a little bit different. The waves are actually lasting a little bit longer than 6 to 8 weeks, depending on where that disease is happening and how many control measures are in place and how many people are actually following the control measures. And I'll talk about that in more detail in just a minute. If we look at the worst pandemic, flu pandemic in history, that was the 1918 Spanish flu pandemic. It actually had 3 different waves of cases. The first wave in spring of 1918 was very mild disease, and it was the smallest of the 3 waves. Then we had sort of a lag that took place over the summer months. And then in fall of 1918, we had the massive second wave. And in between, the virus had mutated. So influenza viruses are known for this. They mutate very, very rapidly. And in this case, it actually mutated and got a lot worse. It went from a very low mortality rate in spring of 1918 to a very high mortality rate in fall of 1918. And so we saw not just a large number of cases, but a very large number of deaths related to Spanish flu. Then that second wave went away. And then in winter of 1919, we had a third wave that was the second highest wave of the 3. And that high mortality rate stayed with that particular wave of patients. And then it finally went away after the winter of 1919. So again, no one knows for sure exactly what's going to happen with COVID-19, but there are 3 possible scenarios for what could happen. So the first scenario is that the wave that we saw this spring and summer could be followed by smaller waves that occur over fall and winter and just keep going over the next 1 to 2 years gradually, slowly maybe stopping in 2021 or later. Now, the waves could vary by geography and might depend on, or probably will depend on, what control measures are in place and how many people are complying with them. Scenario 2 is that first wave that we saw in spring, which actually kind of lasted through the summer, is followed by a larger wave in the fall or winter of 2020, and then we might have 1 or more smaller waves in 2021. This is what we saw with Spanish flu and also what we saw with 2009 H1N1. So This scenario would require us to implement much more stringent social distancing and restrictions in order to minimize morbidity and mortality, and keep people as safe as possible. And then the third scenario is that that first wave that we saw in spring and summer might just be sort of a slow burn of kind of ongoing transmission, but without a really clear wave pattern per se. The actual number of cases would vary because, again, it depends on what control measures we have in place and how many people are actually following them. Now, of these three scenarios, most pandemic experts think that scenario 2 is going to be most likely. I agree. This is where I fall on this. Most of our past influenza pandemics have occurred in this pattern where you have a first small wave and then a second massive wave in the fall. And so that's what I would anticipate that we're going to see this fall. In addition, a lot of viral respiratory illnesses tend to occur in the fall and winter months, including seasonal flu. So it just makes sense that we would see a big wave this fall, and not just of COVID-19, but also influenza as well. And in addition, human coronaviruses circulate every year, are seasonal, and most of them happen in the fall and winter months. So again, I just think that fall and winter are going to be much worse than what we've already seen so far. But again, we don't know for sure. So what do we do to control pandemics? Well, we do screening and isolation. So we look for people who are infected. We test them. If they are found to be positive, then we place them into isolation. We place people who have been exposed into quarantine. Early on during pandemics, we use quarantine of like the ships or airplanes to stop it from even getting into the country. Now, of course, pandemic's already here, so quarantining from other countries is less effective at this point because it's already here. So now we just use quarantine to stop it from spreading further. We also use pharmacological interventions, which I'll talk about in just a second. And then lastly, social distancing. So social distancing are all the, what we call non-pharmacological interventions. So nothing that involves a medical product or vaccine of some kind. So it includes things like closing schools and childcare centers, canceling public gatherings, trying to keep everybody 6 feet apart, having people, telework, and then mask use in public, to name just a few interventions. So pandemic vaccines. So if we develop an effective vaccine, that's going to be our best intervention for this pandemic. However, we don't know exactly when a vaccine is going to be available. Originally, we said 12 to 18 months at the earliest. We have SLU researchers who are looking at a number of different COVID-19 vaccines. And I've been told from one of those researchers that he actually estimates that we might have a vaccine available late fall, early winter. If it is available at that time, it's going to be under what we call an EUA, an emergency use authorization. We don't have time to go through, so to get full FDA approval for a vaccine takes many, many months because you have to have not just a large number of people tested in clinical trials, but also you have to look at the long-term impacts of that vaccine. And we just don't have time to do that. So if we release a vaccine, it will probably be as an emergency use authorization available hopefully this fall or winter. But then once we have that vaccine, we have to convince people to actually take it, which becomes much more challenging when the vaccine is released as an emergency use authorization. And just, it's sometimes difficult to convince people to get vaccinated at all. And even if we do convince people to be vaccinated, we need some kind of a mass vaccination plan. So once we have the vaccine, we need to get it out to millions of people very, very quickly. So we need to have a plan in place. So in general, the vaccine is probably going to be delayed, kind of like the cartoon on the slide where the supplies showed up entirely too late for the poor person on the island. The vaccine, same way. We're already months into this pandemic. It would have been great to have a vaccine at the very beginning, but of course we didn't. But it really can't come too soon. That would be the best intervention that we could have, would be a pandemic vaccine that actually works and is safe. So instead, we're sort of left with the social distancing measures. The purpose of social distancing is to flatten the curve, and I'm sure you've all heard this term before. What we mean by flattening the curve is that we're trying to spread out the number of infected people. So it flattens that peak or that wave of infected individuals, and that allows the healthcare system to be able to take care of those infected individuals. It might last longer, but at least it's not as high of a peak and we're not turning people away from the hospital. So flattening the curve can result in decreased mortality over time. Mostly it helps the healthcare system be able to function fully and be able to minimize mortality by being able to admit everybody that actually needs to be admitted to the hospital. Europe has actually flattened the curve, much more so than the United States. In the United States, we have not been able to flatten our curve, not because we haven't had the correct restrictions in place, although in some places we haven't had the correct restrictions, but more so because there aren't sufficient numbers of people complying with the recommendations to actually make a difference and flatten our curve. There are also some who argued that we reopened too soon, that we really didn't shut down long enough. I actually don't agree with that. I think that reopening is fine as long as we reopen with social distancing. So as long as we can stay open where people are able to keep 6 feet apart and wear masks and perform hand hygiene, we should be able to have a relatively normal functioning society, but still be relatively safe. And we're seeing that in Europe and Asia, and we're not seeing it in the United States because we can't get people on board consistently with wearing masks. So the length of time in compliance with social distancing measures really makes a huge difference in how effective they are. So if you hear people say, well, masks really aren't working anyway, it's because people consistently aren't wearing masks. Masks do work, but we need everybody to wear them in order for them to work. The more compliance we have with any of our social distancing measures, the more effective they're going to be. And then in addition, the longer those restrictions are in place, the higher or the more decreased morbidity and mortality you're going to have. So the more effective they're going to be, in other words. But we know from looking at quite a few studies that Missouri is not very mask compliant. So they did a study looking at all the different states, and we were one of the lowest ranked states in terms of consistent use of masks in the general public. So that is something we definitely need to change if we want to stop disease transmission from occurring throughout our state. So that's my presentation. What I hope that you learned, we know COVID-19 is a very serious disease. It's primarily spread by respiratory droplets. Small risk from the environment, so do keep the environment disinfected, but primarily the main way you can protect yourself is try to stay 6 feet away from other people, wear a mask if you have to be in public, and then wash your hands. So with that, I'm going to stop sharing my screen. And ask, are there any questions? I know I flew through the material.
Harvey Bergman has a question. We can
Yes, absolutely. Thank you for taking my question. The first one is, how do I know my dentist's office is safe? And then I have a follow-on question, but let's do that one first.
So dental offices, if everybody's wearing a mask, then they should be screening you before you go in, and hopefully they are doing self-screening of their employees every day. So their employees should be monitoring themselves for fever and symptoms, and if they have a fever or symptoms, they should not be coming into work. So even if somebody in your dental office was a carrier and they didn't have any symptoms, the fact that they have a mask on is going to protect you from exposure, or at least greatly limit the amount that you would be exposed to.
Okay, and I'm very confused about washing supermarket food that I bring home, washing containers to go before I, get the food out of them. That seems, people are saying you don't need to do that, but that seems contrary to all the recommendations to wash my hands after touching a surface. So I'm very confused. If I don't need to wash those things, then why do I need to wash my hands?
So let's say that the outside of the container was contaminated of whatever the food is, and you dump the food onto your plate or into a bowl or what have you. you need to wash your hands before you eat. So the food inside the container is not contaminated. The outside of the container might be contaminated if an infected person was holding it. And so your hand might become contaminated by picking up that container. But you're not going to be infected from eating that food. The food's not contaminated. So you just would need to wash your hands before you eat, which you should be doing anyway. So.
Okay, and items I bring home from the supermarket?
I'm sorry, what?
Items I bring home from the supermarket?
Yeah, I mean, I always wash fruit. I mean, fruit and vegetables should always be washed anyway if you're going to be eating the outside of them. That's just because they might have pesticides on them or somebody else has had their hands on them. That's just standard practice. But other foods, you don't need to worry about cereal boxes or pasta boxes or jars. I don't worry about any of that. Just wash your hands before you eat and you should be fine. There's not a single case of COVID-19 that has been tied to the contaminated environment, any contaminated environment. Every single case that we have has been tied to somebody being within 6 feet of an infected person for a prolonged period of time without wearing a mask.
Okay, and I don't mean to monopolize the questions, but one last one. I heard there's a thing called runner's wake, where the 6 feet rule really should be longer for people who are out exercising.
So we don't have great epidemiological data about that. So running is, so when I talked about singing and how we think that there's some preliminary evidence that singing or projecting your voice might give more of a burst of virus. It's also possible that exercising, anything that's cardiovascular that is causing you to kind of huff and puff might release more respiratory virus. But we don't have any hard evidence of that. That's strictly theoretical.
I have a question. I have a question. I'd like to, I don't know if you covered this or not, but because I had to leave for a few minutes, but I'm wondering, I see many people on TV and out and about, they don't wear the mask properly. They're not covering their nose. So what's the purpose of wearing the mask if they're not going to wear it the right way?
I agree completely.
I get very angry about it.
It's both your nose and your mouth that pose a risk. I usually politely tell people, say something to somebody about, you know, you need to wear your mask over your nose so it will protect you and protect us. Most people take that very well if you say it very politely. At least I have found that to be true.
Some people could punch you in the nose.
Yes, I mean, you do run the risk.
I mean, it's so ridiculous out there and with the way people are, you know, understanding these things. But I mean, I know they keep saying, well, it keeps slipping down. And I know that my mask, you know, I have I guess there's a piece of metal or something in there that I squeeze and it stays up. So I don't understand why some of these masks, these homemade masks, are not tight enough around their nose and they keep slipping down. But it just it's ridiculous.
Some of them are bigger. My daughter picked up some masks from Target and they were marked as size large. They were like one size fits all, but they were large. And she brought them home, and when she put it on, it gapped. It just like basically fell off of her face. And I'm like, you can't wear that. Like that's not going to work. So yeah, you have to find one that got a tighter fit and will stay up.
So you should stay away from people that are not covering their nose.
I just remember it's 6 feet plus the masks. So if you see somebody who's not wearing their mask correctly, just stay 6 feet away from them and you should be fine.
Mm-hmm. Thank you.
Yep.
I have a question too.
Sure.
Yes, I would like to know when is the best time to get a flu shot? Because should we get it now or should we? Because normally we get it like in October or early November.
I would say get it as soon as it's available to you, because I think that the goal is that you need to have it at least 2 weeks before flu hits your community, because it takes about 2 weeks to build immunity.
And also, what about those nylon masks? And what temperature should you wash a mask, like in the wash machine?
So I just wash my masks with my other laundry, which is on either warm or hot.
Oh,
depending on
that warm is okay?
dark
Okay,
or whites. Yeah.
okay. And what about the nylon fabric? Is there a way to test fabric?
You know, I had that one slide that lists the different material types. I don't remember where nylon.
It's not, it didn't say. That's why I wonder,
Oh,
because it's
maybe
not like a gaiter, it's a mask, but it's, they're nylon.
I don't know that those have been studied yet, and so it's possible that we just don't have the data.
So what do you feel is the best fabric?
So, well, so I stockpile masks for years. So my family and I all use surgical masks because I had
Okay.
hundreds in my basement. But if I had to wear a homemade face mask, and I do have a couple because SLU gave them out to all of us. They gave us a few of them. At least 2 layers is most important. And the thicker the fabric, the better.
Thank you.
Yeah, I've got 2 questions.
Sure.
I have 2 questions.
Go ahead.
Okay. Regarding masks, I have a surgical mask. If I take it off properly and put it on properly, when do I have to dispose of it after each use, daily, or can I keep on using it if I don't touch it? Or is there a way to reuse it because I don't have a lot of them? And the second question is, a lot of people wear masks inside, but when they go outside, they don't. Do you recommend wearing masks outside as well?
I do. So the general recommendation is that the whole time you're indoors, unless you're in a room by yourself with the door closed and no one else is in there, outside, you should wear a mask if there's even the remote possibility you're going to be within 6 feet of somebody. And I never know who's going to like walk up behind me or next to me when I'm out and about. So I just have a mask on the whole time I'm out. That way I don't have to worry about it. That's just the easiest thing, unless I'm running. So because I'm a runner, so I put a mask in my pocket. And so while I'm running, I'm not seeing anybody. If I have to stop at the gas station to go to the restroom, I pull out my mask, put it on before I go inside. But otherwise, anytime I'm outside, I have a mask on. The other question was about how many times can you reuse a surgical mask? So we don't have great data on reuse of masks. There have been a couple of studies that looked at the reuse of respirators, and they found that you can reuse them multiple times safely. But the CDC limits their recommendations, say you shouldn't wear a mask or a respirator more than 5 times. So that's the general guideline. Now that's intended for healthcare. So for healthcare workers, they would wear a mask 5 shifts in a row, and then they would dispose of it and get another one. So I tend to just follow that same recommendation. So my family and I, we use our mask about 5 times, and then we throw them away. Going off.
Hey, how you doing? I'm watching a.
Would
This
you
was
please,
very good.
would you please
They have
mute
classes
her?
and from. Okay, online. No, this is for like the people in our.
Susan, please mute yourself.
I muted him, John. John, did you have a second question?
Yeah, I did. I did have another question.
Plan?
You mentioned, Terri, you mentioned mass vaccination plan by the government. And I was wondering, is there such a thing, or is the CDC or somebody working on a mass vaccination plan? Because it seems like the government always is 2 steps behind where they should be.
Yeah, so the mass vaccination plans take place at the community level. So that would be public health and healthcare that would put those mass vaccination plans into place. For a number of years, communities have been planning for this in case of a pandemic or a bioterrorism attack. We're early on in the fall in terms of like for flu vaccination plans. but I know a lot of organizations are starting to have those conversations. One major challenge is that right now public health is still drowning with the pandemic response. So it's really hard for them to they have no resources to put towards flu vaccination programs right now because they're still trying to respond to the pandemic. So people are having conversations about it, but I think it's going to be challenging this fall with everything going on.
I have a question, again, about masks and washing them. First of all, when we go walking, which we try to do daily, we take a mask along with us. We usually have it folded in a plastic bag. We take it in case we should come into contact or talk with people. We put it back, we fold it up, put it back in that plastic bag. And after, when we haven't seen that many people out and about, I tend to wash it by hand because I'm not washing a load of wash every day. And so is a hot soapy water by hand just as good?
It is. The virus doesn't live very long outside the body, so washing it in hot soapy water is going to be sufficient. When you're storing your mask though, plastic, you need a breathable container. So a brown bag, like a lunch bag, would be much better than a plastic baggie. Or if you're going to use a plastic baggie, just don't seal it because you don't want it to get, you don't want condensation inside of it because it can actually grow microorganisms that way.
Okay. Okay. Thank you. It was a very wonderful presentation. Thank you so much.
Thanks.
Earl Salison has a question. Do you have any idea when schools, especially colleges and universities, will be able to open safely?
Yeah, so some universities have already reopened. SLU is open. We've been open for 2 weeks, I think. WashU is getting ready to open, I think, next week. Mizzou has already opened. So some universities are opening. Others are moving to online. So it's a little bit different. The K through 12 schools are, very few of the K through 12 schools are currently planning on opening this fall, or at least not right away, mostly because we have such a high community rate of disease right now in St. Louis that a lot of the schools are choosing to stay online for a while before they decide to reopen. But every school or school district or university gets to make their own decision.
I have a question.
Uh-huh.
This has to do with your estimate of how long you think that the social distancing and the masking and everything that we're doing will probably go on, because a vaccine isn't even out, and then once it is, it has to be, distributed through the community. So in your estimate, how long do you think all of this is going to be continuing?
So my guess is that the earliest that things are going to sort of get better is probably winter. So if we have a huge peak this fall, it could go away in the winter, or could go down in the winter before we might have another peak in cases. When we see a decrease in cases for an extended period of time, usually about 2 weeks, which is the incubation period, then the public health officials start thinking about loosening restrictions. So you have to see that decrease over an extended period of time because you don't want to loosen too soon. Otherwise, you'll see another rise in cases. So my guess is that either we'll start to see a decrease in cases this winter, or we'll get a vaccine late fall, early winter, and we might be able to loosen things in the winter. But I just don't know for sure exactly if that's going to happen.
Well, everyone would have to have the vaccine before we could go back to normal.
A large number, yeah. So you need what we call herd immunity. So you don't need to have everybody immune in order to have protection against the disease, but you have to have a large enough percentage that the people that aren't infected don't really have a chance of being exposed to the disease. So every disease is a little bit different, but it's at a minimum like 80% of people will either need to be immune to the disease naturally or from vaccine.
So you're talking about possibly next spring.
At the earliest. I don't want to be too negative, but it's.
I agree. I'm agreeing. I mean, the earliest would be next spring.
Most likely.
Okay. Thank you.
John, do you have another question?
I just have
Just
one
more
quick,
questions. I've got one. I got two more. What's the response to getting test volunteers for the vaccine? At St. Louis, WashU. I know that there are requests out for volunteers.
Yeah, my understanding is that we have not had a problem recruiting volunteers for the study.
Okay, the next question is, you haven't talked about testing really, and the effectiveness of testing, and there's a discussion about does everybody need to get tested and how often and so on and so forth.
Yeah, testing, so there's different kinds of tests. So there's antibody testing and then there's diagnostic testing. Antibody testing is too early and it only tells you whether or not you've been exposed. So I'm not going to talk about antibody testing. The diagnostic testing, technically there's a third category. There's screening testing, meaning you don't have any symptoms. We're not trying to diagnose you. We're just testing you to see if you have it, if you're an asymptomatic or pre-symptomatic carrier. Screening and diagnostic testing, the effectiveness of the test or the accuracy of the test depends on the test that's being used, because there are multiple tests that are currently available. In general, there is a lack of testing available in the United States. We don't have enough test kits, and we don't have enough reagent to run the tests in the lab. So, like locally in St. Louis, it's really challenging to get tested, except in certain situations. So for instance, some of the mass testing sites, some of the drive-through sites are changing their policy about who can be tested. And I'm sure many of you heard the CDC recently change their recommendation, and they are not encouraging asymptomatic people to get tested anymore. But for a while over the summer, they were allowing anybody to get tested basically for any reason. They've now restricted that again in some areas. In some places, you can still get tested regardless of whether or not you have symptoms. The testing is good, but there's also some limitations to it. So testing only tells you what's going on today. So for instance, if I got tested today, I don't have any symptoms. If I got tested today and I'm negative, that means I'm negative today. It actually doesn't tell me anything else, because I could develop symptoms tomorrow and test positive, because your infection status changes depending on when you were exposed. So really the only way to have accurate information from testing is to test everybody every single day, which isn't possible nor feasible to do. So testing is just one tool that we use to respond to the pandemic. And there's been really an overemphasis on testing. Which I think people have this idea that if we just did enough testing, we could kind of go back to normal. And it doesn't work that way. We're not going to be able to test our way out of this pandemic. We really need to do the social distancing measures and use testing for diagnostic purposes, and to confirm illness, or if people have a known exposure, test them to see if they're an asymptomatic carrier. But wide-scale testing of everybody all the time, it just isn't. We don't have the money nor the resources or the infrastructure to make that work.
We have two more questions. Phyllis Hyken asks, do you think that Missouri has a high rate of COVID because we have a Republican governor?
I think that Missouri has a high rate of COVID-19 because some areas do not have strong mask policies and social distancing policies, and even the areas that do have low compliance. And so the problem is that we know that masks and distance and hand hygiene work, but we're not doing it consistently across the state, and that's why we're seeing disease spread.
And then Maxine Merowitz has a question, and she wants to know, do you feel air travel is safe with a mask?
Air travel is riskier. Any public transportation is riskier than staying home. Airplanes are a contained space, lots of people sharing the same air. It's relatively crowded depending on how many people are on the plane. So it does pose a level of risk. It's hard to quantify exactly what that risk would be because it depends on, even if everybody's wearing a mask, it depends on how many infected people are on the plane.
I have one more question about this saliva test that has come out, and you can test at home and for $5 and get the results very quickly. So if they mass produce that test, everybody can can test themselves and get results every day if they want. And for $5, that sounds like a much better option than sending out a COVID test to a lab that takes 5 to 10 days or even longer.
Yeah, so
think of the
testing
saliva
is,
test. They said it was like 95, 98% accurate too.
yeah, testing is becoming more available every day. We're getting better tests that are less expensive, which is great. But we still don't have, even those brand new saliva tests, we don't have enough access to those right now for everybody to test themselves every day. It's just not, that's not an option right now. Hopefully that will be soon. And I do think that when test availability when we have more access and when costs go down, we will probably start to see an increase in the testing that's happening.
Okay. It's a good option. I hope they do increase the amount of those tests.
I agree, and the saliva tests are just easier to do than the NP swabs are very uncomfortable, and if you don't do them correctly, you don't get accurate results. So they're a challenge.
Mm-hmm. Thank you.
Sure.
So John, you had one more question. Do you feel, air filtration is effective, and which one, HEPA, etc.?
So if you remember that slide where I talked about the risk of this disease, like there's lots of factors, right? And one of them is the number of air exchanges in a room and whether that air is filtered. But that, in my opinion, you don't really need to add a lot of extra filtration for a space. This isn't an airborne spread disease. So these particles are not going into the air and staying airborne for long periods of time. That being said, if you're in a smaller space and there's not much air movement, if it's very stagnant and you don't have great air exchanges in that space, then having some kind of filter or some kind of HVAC system that increases those air exchanges will provide a certain level of protection, but that has to be balanced with the cost and feasibility of providing that filtration. We don't have great data that says that you need to invest a lot of money in filtration systems at this time. Again, it comes down to distance and masks and hand hygiene.
Well, I think that we're pretty close to ending with, I don't think there's any more questions. Anyone have another one? John, what do you think?
I think we need to thank Terri and give her a round of applause and tell her that she's been very informative. We've all learned a lot from listening to this presentation, and thank her for her time and thank her for her service to the community and the nation.
Thank you very much.
Thank you,
You're
Terri.
very welcome. Thanks for having me today.
Thank you, everyone. Bye.
Bye-bye.